All right. Then the next ones were the gluteal arteries, right?
Yes, superior and inferior gluteal.
Can we skip those for now because they won't make sense without the other arteries from the lower limb?
Okay.
I'll come back to them with the other arteries of the lower limb. The next one was
Anterior
sorry,
pudental.
internal.
Internal pudental.
Yeah. So internal pudendal gives you specific branches which you can use to remember where it's going. For example, remember I said it gives us inferior rectal artery.
Yes.
It also gives us an artery called perineal artery for the perineum. Right. Then it gives us an artery called artery of the bulb. What's the bulb? Do you have a bulb in humans?
I don't know of that.
Yeah, so it's there. So if you look at erectile tissue, be it male or female, at the center, the mass of erectile tissue at the center, if it's a male, if it's a female, we call it bulb of the vestibule. If it's a male, it's bulb of the penis. And so there's an artery of the bulb which goes to supply that erectile tissue. Right. Then, yeah. Then the other mass of erectile tissue on either side, they're called crus. There's a right crus and a left crus. But those, they're not important.
Okay.
Then
I need a minute. I'm figuring something out. What is a perineum? Because we said we have perineal artery, right?
Yeah.
But I'm not understanding what it's supplying.
So for perineal artery now, right, we'll now say it supplies all the other structures in the perineum that are left. For example, the labia major, the labia minor on the internal surface. Right. So perineum simply means genitalia.
Okay.
Right. But for those genitalia, we have arteries that are specific to other genitalia. For example, we're also going to add dorsal artery of the penis and deep artery of the penis, meaning there are specific arteries going to the penis. It's not going to rely on the perineal artery. But everything else that's left in the perineum, for example, the scrotum, it will get its blood supply from that perineal artery. You're getting it? It's all perineum, but there are more important things there. For example, the penis. For erection, you need a good arterial blood supply and a poor venous blood drainage.
Yes.
So there are specific arteries going to the penis. For example, there is a deep artery, then there's a dorsal artery, which are also branches of.
Okay, now I get it.
Right. So they are also branches
Makes sense.
of internal pudendal artery. So the two branches that are left there, it's deep artery of the penis and dorsal artery of the penis. Right.
Okay.
For the female, you just change the word penis and then you put clitoris. Right. Okay. For the female, you also have inferior rectal artery, perineal artery, then you have a deep and a dorsal artery of the clitoris now.
Okay.
But this one, you need to know more about it. This perineal artery, where do you find it? Please don't look at this poor diagram.
Okay.
Where do you find the perineal artery?
Where do I find it?
Yes. It's no, not the perineal, the internal pudendal artery, sorry.
Oh, this one.
It's found somewhere specific.
Okay, where is that?
Trying to find a diagram. We call it the pudendal canal or Alcock's canal. Have you ever heard of a greater sciatic foramen and a lesser sciatic foramen?
Yes.
Ah, good. You've done the bones, yes. So I can't
You
seem
said
to.
it's called pudendal canal or
Alcock's, A-L and
Alcock's.
Alcock's, A-L-C-O-C-K. Like you said, you heard about greater and lesser sciatic foramen. Like, why do we need the two foramen?
A sciatic foramen.
Yes.
They are for passage of my vessels.
Why should vessels
From-
pass through?
From the you said it's called the fake pelvis.
No. You know the answer, but you're slightly swaying away from it.
What I know is foramen, usually it's passage of my vessels, and
Yeah.
yes.
Okay.
So now,
Okay. Remember, I asked in relation to internal pudendal, and we're saying it's an
pudendal,
artery
yes.
of the perineum. Perineum and pelvis are not the same. Right.
Okay.
So here's what happens. The pelvis, we divided it into false pelvis and true pelvis, right?
Mhm.
Then you've come across a muscle known as there's no diagram of the rectum. Muscle known as pelvic diaphragm. Have you?
Mm-mm. Mm-mm.
Okay. Let's see if I can find the diagram to make it make sense. This muscle, the pelvic diaphragm, what it simply does, it separates pelvis from perineum. Pelvis, yes, you can divide it into false and true. Right? False pelvis, others prefer to call it the greater pelvis. Then true pelvis, others prefer to call it the lesser pelvis, depending with who you are or which book you're using. But below the pelvis, there's something called the perineum. So can you see this muscle here? Yeah, this one.
Wait, I can't see your pointer.
Or like everything that you're seeing on the picture.
Okay, yes.
Right.
The
Please.
pelvic floor.
That's the pelvic floor. And the muscle, collectively, we call it the pelvic diaphragm. So we are seeing from above here. Everything in the pelvis sits on top of it. That's for support. Then everything below the pelvic diaphragm, it's now in the perineum.
So my question is, what is above and what is below?
What's above, it's pelvic organs like the uterus, the bladder. You have half of the vagina. You have rectum. Then when you go to perineum, there is the lower half of the vagina. Then there is the anal canal. Then all the other genitalia. Right. But point is, so can you see these openings in the muscle there? Those openings allow specific things to move from the pelvis to the perineum. This anal aperture here, that's where the rectum passes and becomes the anal canal.
Okay.
This one in front here, it's this big in females for the vagina plus the urethra. For males, it's very, very small because there's only the urethra. Right. Then imagine the arteries. How then do they get to the perineum? For example, that internal pudendal artery. Right? So it's like you're in a house. You want to connect your you want to connect your charger or your long cable to the next room, and you can't pass through the wall. The wall in this case is the pelvic floor. Unoburitsa tambo nepa window, then uipinza nekune rimwe window. That's why you have two maforamina. There's a greater and then there's a lesser.
Oh, so the greater is the one that's passing them outside and then they enter through the lesser.
So greater inoburitsa zvinhu mu pelvis yozvisa mu gluteal region, which is now part of the lower limb. Then zvinhu zvapinda mu gluteal region zvoda kudzoka back into the perineum now, zvinopinda nepa lesser. And one of those things is internal pudendal artery. Right.
Oh, understood.
And this internal pudendal artery is the artery of the perineum. Ndosaka iri kudzoka nepa lesser sciatic foramen. Right. But painopinda nepa lesser sciatic foramen. Forgive me, I don't know why I can't find a diagram, really rectum or something. Painopinda nepa lesser sciatic foramen papo. It goes straight into let me just search. It goes straight into that pudendal canal. This is not what I want. Maybe I should find something here. Finally. It goes straight into a canal that we call the pudendal canal. So forget which side of it is you? Okay, look at the left side. Okay. Can you see this small canal karipana back? That's what we call the pudendal canal. And there's a blue, there's a red, and there's a yellow in that canal, meaning there's a nerve, there's a vein, there's an artery.
And an artery, yes.
The vein corresponds to the artery, so it's internal pudendal vein. The nerve, we simply call it pudendal nerve. Because there is no internal, there is no external, it's only one. So it's only called the pudendal nerve. So it's worth to know that the internal pudendal vessels lie in that pudendal canal. So when you do your pathology,
so
there'll be
where is the pudendal canal coming from?
This one.
Yes.
It's a groove in bone.
But where is it coming from?
What do you mean?
Because until we said the greater foramen is the one that kumburitsa vessels, and then they enter through the lesser foramen. Is it related to that or?
Oh yeah. So as you go in via lesser sciatic foramen, you go straight into the pudendal canal.
Okay.
Right. So people tend to think that it's an opening or a canal in bone, but it's not. It's just a sheath, right? Which is coming from the fascia that overlies this muscle here, which is obturator internus. So the fascia that overlies the obturator internus, the white fascia here, it forms a sheath around blood vessels there.
Okay.
That's what we call pudendal canal.
Okay.
And what do you call this space where the fat is?
Fossa.
It's a fossa. Fossa what? Oh, you're reading from the...
I don't know what it's called.
So, yeah, so back then it used to be called ischiorectal fossa. But it's more associated with the anal canal, so it's more appropriate to call it ischioanal fossa. Okay. So it's still the same, ischioanal fossa, ischiorectal fossa. And I think that's one of the most common sites, equitama abscess. Right. Okay. And I've seen someone so all this here will be skin, pane skin. So I've seen someone who was was having an ischiorectal abscess, to drain that, unoborwa the skin here. Then again this side. So you now have 3 openings at the back. But they will close spontaneously and it's very painful. You won't even be able to sit.
Yeah, okay.
Right. But anyway, point was internal pudendal artery goes into that pudendal canal. Right.
Okay. Yeah, I understand this canal very well.
Then the next one was what?
After internal pudendal, inferior vesicle for the bladder.
So inferior vesicle, it's simply going to the bladder.
Mhm.
But it also gives us branches to the prostate. So when you look at male organs, there are 2 organs that have the same blood supply: the prostate and the seminal vesicle.
Right. I want to ask you something.
Yeah.
Because you're my teacher. What is prostate?
What do you think?
I have heard of people getting prostate cancer, and and I hear this word a lot. But for me to really say this is prostate, I don't know what it is. Is it just the
So-
male genitalia in full, or
No. Like, have you guys done reproductive physiology?
no? Physiology hasn't reached that part.
Right. So for males, so this is the bladder. Above. Just below the bladder, there is this. Can you see something that's looking like a heart here, but it's not really a heart.
Mhm.
It's a fibromuscular glandular organ. Fibromuscular in the sense that it is a fibrous capsule and muscle on the outside. Glandular, it's made up of glands.
Okay.
Remember histology of glands. There are tubuloalveolar glands, tubuloacina, what. This one,
Yes.
it's made up of 30 to 50 tubuloalveolar glands. Right. And these glands, what they simply do, they help with production of semen. So semen is called semen because it comes mostly from the seminal vesicle, 70%. But 30% of it comes from this prostate. And without that 30%, you're infertile. Right.
Even
So
if
since
you
there
have
are
the other
glands,
70%.
sorry?
Even if you have the other 70%.
Yeah. So the constituents are different. This produces an alkaline phosphatase, acid phosphatase. There is a physiology around it.
Okay.
So as you age, it's a gland. So all those glands, they are prone to enlargement. And the bad thing with the prostate is it feeds on testosterone already. So when you are a male, you have a lot of testosterone. 2, you have the prostate itself. Females don't have all these things. They don't have a prostate, they have little testosterone. So that testosterone, it's converted to something called dihydrotestosterone, which causes enlargement of the prostate. That's how almost more than 50% of males after 50 years, they get benign prostatic hyperplasia, but it's not yet a cancer. Then the unlucky ones, they get cancer now. So the way you treat the 2 will now be different. For cancer, we may need to remove the whole prostate. These ones who just get an enlargement, we just need to remove a chunk of it. It's called TURP, I think, transurethral resection of the prostate. TURP, TURP. But to treat it medically, you need to give something that antagonizes the dihydrotestosterone, or something that blocks its receptors. But treatment for prostate CA, it's expensive if it's medical, because you need to have, I think, an injection every 3 months, and it goes for like 500 to 1,000 bucks. And in our setting, People don't have that. And when you inject the patient, the first week they deteriorate, then they get better. It's like you're treating someone, then they get worse first, then they get better after some time. So people just then tend to remove the prostate. Others, they prefer medical castration, where you just remove the testis, which is producing the testosterone. But
Okay.
it's something interesting.
Thank you.
This prostate.
Yeah, it is. Yeah.
There's a whole lot about, especially the histology. Anyways, I had a question for you when I talked about dihydrotestosterone. So this is dihydrotestosterone when it's bad. What about when it's good? Why do we need dihydrotestosterone? In particular to embryology. I know I talked about it, that's why I'm asking.
I think for formation of the male organs in the baby.
Male organs is broad. So you want to form male external genitalia. Do you remember when I said you can have a testis, but still go on to form female external genitalia? Those babies who have androgen insensitivity syndrome, you have the testosterone, it's converted to dihydrotestosterone. You need that dihydrotestosterone to stimulate development of external genitalia for the male. If you then don't have that stimulation, you can be male inside without a uterus, a uterine tube whatsoever, but you start to form a clitoris and a vagina on the outside.
So homosexuality is not spiritual.
I don't think it is.
Okay.
But yeah.
Okay.
So there's a way I used to tell people. So remember I said semen is coming from prostate and seminal vesicle, the two of them.
Yes.
So these two have the same blood supply too.
Let me write this down before I forget it. As a side note. Semen, 30% is from the prostate. 70% is from, it's semi what?
Seminal vesicle.
Seminal vesicle. Okay.
Right. Then those two, they get their blood supply from inferior vesical artery and mid-rectal artery.
Let's apply from
inferior vesical artery and mid-rectal artery.
mid-rectal, we said is the one
which comes directly from internal iliac. Right. So from its name, you know it will go to the rectum. Now you know it gives branches for the prostate, branches for the seminal vesicle too. Right. Then, what was the other thing there? Besides that, so inferior vesicle can also give us artery to vas deferens. Remember, artery to vas deferens, we said it's mostly a branch of umbilical artery. Right.
Inferior vesicle. It can also give a branch to
vas deferens. So we call it the artery of the vas deferens or artery to vas deferens.
Vas deferens is too vascularized.
No, it's not too vascularized. We said, okay. So the common thing is the artery for the vas deferens, it's coming from umbilical artery, right? But in other instances, we may not have that umbilical artery. That's why we say superior vesicle can also be a direct branch of the internal iliac. The artery of the vas deferens, if there is no umbilical artery remaining, it's a branch of inferior vesical artery. So it's either or.
Okay.
It's either we are coming from umbilical or
Mhm.
we are a branch of
Vesicle.
inferior vesicle.
Okay.
Okay. Then what then vesicle, don't forget it means bladder. Right.
Yes.
Then there is superior vesicle too. Right. It also goes to the bladder. So can you just find like somewhere beside pekunyora ureter? So the ureter has 3 blood supplies. And here's how I want you to remember. The ureter joins the kidney to the bladder, right?
Yes.
So in the upper part, the upper third, the ureter gets its blood supply from the artery of the kidney, which is the renal artery.
Yes.
Then the lower third joins the upper surface of the bladder. So its blood supply comes from the artery that supplies that upper part of the bladder, which is superior vesical artery. So upper third, it's renal artery. Then the lower third, it's your superior vesical artery, right?
Mm-hmm.
Then what's left now is the middle third. So middle third now depends on either if you're male or if you're female. So it's the gonadal arteries. For males, we are thinking testicular artery. For females, there is ovarian artery. Right. Meaning testicular artery and ovarian, we mentioned them per 3 lateral visceral equabdominal. And we're saying they're going all the way down to the testis and the ovary. Along the way, they give blood supply to the ureter
The ureter. Okay.
before they get to where they want to go.
Okay.
Then after the vesicles, what's left?
Mid-rectal.
Mid-rectal, no need to worry much. It goes to the rectum. Then it also gives blood supply to the prostate and seminal vesicle. Then vaginal artery goes to the vagina, nothing much about it. But what I may want you to see is uterine. So obtuse artery, we also describe it with the lower limb. It's going to the lower limb.
Okay.
But the only question is, how does it get to the lower limb from the pelvis? You've done the bones.
Yes.
And you have seen this foramen here. This big hole here. The obturator foramen. It's called obturator foramen. Why? Because that's where you find the obturator vessels there. So here's what happens. Obturator foramen is closed by a membrane like this, which we call obturator membrane. Then it leaves a very small gap at the top there, which we call obturator canal. Through that obturator canal, that's where you find the obturator vessels. So there's obturator artery, vein, then the nerve, passing to the lower limb to go to the medial thigh. They will supply the medial thigh. So when you then look at the muscles, I think you mentioned a muscle called obturator internus.
Yes.
Right. That muscle, we're simply calling it internus because it's originating from the internal surface of this obturator membrane that's closing the foramen. When you go on the outside, there's a muscle called obturator externus. We're calling it externus because it comes from the outside of this obturator membrane.
Okay.
So all those names, they have reasons for them. So obturator artery passes through that obturator canal to get to the medial thigh. Then uterine artery, most importantly, if you had to ever do a C-section or if you had to do my removal of the uterus, there's a word for the procedure. It must be called it's hard to pronounce. HYSTE. Hysterectomy. Yeah, something like that. If you're removing the uterus, remember, if you remove an organ, you need to remove its blood supply.
Okay.
The bad thing with the blood supply of the uterus, not necessarily to remove, but you need to close it off because they'll bleed.
Okay.
So there's no good diagram, but the bad thing with the blood supply for this uterus is it crosses the ureter. So there's a mnemonic that's used which says water under the bridge. The ureter is carrying water basically, which is urine. Then the bridge is the artery. So when you're trying to clamp the artery to close off the blood supply, remember, if you're operating an organ, you may need to clamp its blood supply so that you don't really vascularize it. You can clamp the ureter, and if that happens, one.
Okay.
And I think one of our lecturers did that, and they had to, like, unengo separated the ureter now. So agata our agamabata agada so. Because urine will now be going everywhere. And urine may be, people say urine is not that bad. You can drink your own urine. Remember, people will survive in deserts, they won't die. But that urine ikagara, it becomes cytotoxic. Remember, epithelium urinary system, it's urothelium with more than 3 layers to protect those layers, because urine ikagara, it starts to erode. So iwoka bleed now mu uterus mu. One.
You mentioned something. You said epithelium.
Urinary system, which is mostly the blood, urothelium or transitional epithelium. So you can call it urothelium or transitional epithelium.
Just 3 layers.
Yeah. Basal layer with stem cells, middle layer with 3 to 5 cell layers of columnar cells. Do you remember those things?
I don't. Middle layer with
3 to 5 cell layers.
Okay.
Then the superficial layer is the one with the umbrella cells, umbrella-shaped cells, to allow for distension, which is one of the reasons why you can feel the urge to go to the toilet, but you can hold your bladder for as long as you want until maybe you get to a certain pressure, because those umbrella cells, when they start to go flat, you're increasing the surface area so you can hold more urine. That's why you need an epithelium with umbrella-shaped cells.
We never talked about this.
I'm going to play that recording. I'm going to play that recording.
Okay.
Anyway, so uterine artery problems come with hysterectomy. Right. Then this artery, it gives blood supply to the uterus. It gives blood supply to the uterine tube, or you can call it oviduct, right?
Yes.
The uterine tube.
Yes, it's the oviduct.
Yeah, then so it gives blood supply to uterus, uterine tube, and most importantly, it gives a vaginal branch.
Okay.
So an artery can be called branch. For example, I'm saying there's a vaginal branch. There's vaginal artery. Those two are different.
Yes.
There's vaginal branch of uterine artery. Then there's vaginal artery coming from internal iliac.
Internal iliac.
Then maybe something which we may also not have talked about. Can you see the uterine tube?
Yes.
So God is amazing in the sense that it's between two things. It's between ovary, it's between uterus. So half of its blood supply will come from the ovarian artery, half of its blood supply will come from the uterine artery. So that ovarian artery, which we say it supplies the ovary, would also give us a branch to the ureter. It also gives us a branch to the uterine tube. So uterine tube is just between two things, the ovary and the uterus. So it will get blood supply from either ends. Right. Then did they leave out an artery from the internal iliac besides my gluteal?
Yes, you said obturator would do it with the lower limb.
Yeah, okay, obturator, yeah, it's partly lower limb. So do you want me to proceed to blood supply of lower limb? You're interested?
Yes.
Yeah, it's all right.
I have a question.
Yep.
How did you handle your studying in your second year?
What do you mean?
Like, how do you study? How many hours do you study? What techniques did you use to study? Like, did you use my textbooks, or you revise what you learn in class, or you used YouTube?
I personally,
what's the best way to memorize?
I'm someone who can regurgitate a video or something that you tell me. So mostly I'm an active listener because I find it hard to read a book. Because you find you go into a book, then it's talking about lateral media or superficial deep, you won't even picture it. But if you see maybe a video or someone talk, it becomes easy. So I never really used to use the core text, but whatever I would get from the video, it would probably be what's in the core text plus something that's useless. But there was no harm in knowing it because there will always be those tricky questions which are not in the book. But I was more of my videos, even for physiology. I like the videos by, you've heard of USMLE, right? That program you kwenda ku states, right? Must be states, like those exams. They like one more of my lectures for people who want to take the exams. But somehow their videos, they sell videos, but those videos they leak somehow. So I think I've their videos for physiology, partly pathology, and all the way to part 5. They're only bad for anatomy, but everything else they're good. So I don't know if what Ndoma share say my video because they're quite large. But yeah.
There's no link. Like, I thought my videos that you actually have.
Yeah, I have them as videos because I know someone who bought them, then they gave it to me.
Okay.
So I'm not sure if you have a Google Drive, very free, or I don't know, then I can just try upload them there. When I
check my drive, kuti inovomidzwa space yakaita sei. And then how many hours did you study per day?
We used to do lectures 8 to 5. So I would mostly read for like 3-4 hours, but it was consistent with or without an exam.
3-4 hours per day.
Yeah, so you'd find good when you get towards the exam. I won't have too much pressure. I now need to read a lot back then because it was consistent. And